So today we have this is a special meeting, not just because it's Leap Day, but because some of us heard Dr. Hoefer speak a few months ago, and we were so impressed with what he had to say that we thought we had to have him here for you to hear what he has to say. It's so important. We've given different titles to this talk today. I call it one thing, he probably doesn't approve of that, but the way we advertise it is aggressive medical treatment. If only someone had warned us. I'm going to go with that title until you tell me otherwise. But Dr. Hoefer is the CMO of the Outpatient Palliative Medicine Department at Sharp Hospital. And I think you will be as impressed as we were when we heard him speak a few months ago. So with that, Dr. Hoefer.
Thank you very much. So the first thing I have to say is this is by far and away the best stage I've been on. You have a chair, it's like a Netflix movie where you get up and speak and you have the counselor in the back, and so I'm very happy to do this. How many people in here are healthcare providers? Healthcare providers, doctors, nurses. So a few healthcare providers, good. And anybody want to yell out what professional careers you've had? Law, legal, anything else? Technical, financial, so good. You're a part of the humanity and you are very intelligent. I've always said once you retire, doesn't mean you lost all your knowledge. You're still intelligent folks with lots to contribute, and you need to understand what's going on about your health as you move forward. So I'm going to give you some information. It's new and evolving. Don't get mad at your systems or your doctors yet. It's brand new. We're learning these things. And it is because we've been able to keep people alive so long that we're learning a new evolution in healthcare. And by the way, the talk that you were talking about, why didn't anybody warn us, is a different talk I do, even more highly technical than the one I'm going to give today. And so she's probably thinking about a different talk. Anyway, so I'm going to go ahead and get started. In geropalliative medicine, I'm going to see if, can I turn this a little bit so I can talk and look? Yeah, not really. Let me walk this, let me turn this way. So why geropalliative medicine should become mainstream in all specialties? Everybody, have you heard the term palliative medicine? Yes. Have you heard the term geriatrics? This is geriatric palliative medicine, making sure the care you are getting from your doctors is consistent with your goals of care. Not just treating the heart, the lungs, the kidneys, your diabetes, your blood pressure, but understanding what it means in the context of the human beings surrounding the organ systems that we treat. So since it's a medical talk, how about this? Better. Does that work for you? Even better. I have no financial disclosures. Yeah, otherwise you're going to have to see the bald spot in the back of my head a lot. We're going to be talking about the changing paradigm that we understand in geriatric medicine. There's new, evolving understanding about how to treat people. The conflict between traditional management and evidence-based, up-to-date standards in geriatrics. We're going to talk about the importance of prognosticating risk, knowing what you're getting into. You pop out the other side and we say, oh, well, it just happened, but you know, you should have known that before we went there. And we're going to be able to, for doctors, they should be able to at least name 3 things that could have been done in a traditional physical that are not being done now to improve care for the elderly population. So if I were to ask you this question, you're the audience, you are the people that we treat, you are the consumers of what I provide. I talk to you, go into the hospital, I talk about a procedure, an intervention. What does a good outcome look like? Come out singing and dancing. What was the one over here? So it is individual. Going to sleep quietly. So going to sleep quietly. But I would... Thank you. This is the most common answer is I want to be able to go back to where I was before, and I want you to have fixed the problem that I came to you for. What's the problem in healthcare right now for the elderly population? We fixed the problem you came in for, but you don't always go back to the way you were before. because we don't know how to look at those issues yet. I'm going to show you where that stands in healthcare. So these are traditional research and healthcare metrics. Let's say you go into the hospital for a pneumonia or a hip replacement, or you had a heart attack, you have a heart procedure. We look at whether the patient survives. Of course, that's important, and that's what we look at in research. We'll look at whether you had a stroke or a heart attack or kidney damage. We'll look at the financial burden to the healthcare industry for the procedures that we create. But palliative medicine asks the questions that you're asking. Of course, I want to know if I'm going to survive, but am I going to come out autonomously, living the way I was before? And am I going to be able to speak or recognize my loved ones? That's separate from having a stroke. How many of you know you can go into the hospital and be cured perfectly and come out and not recognize your loved ones? Am I going to be exhausted in chronic pain? Will I be moved to an institution? And what will be the emotional and financial burden to my family? Are those meaningful metrics? Which metrics are we using when we look at a patient like Terry Schiavo? To this day in the American healthcare industry, according to the American Heart Association, the American Medical Association, you are considered a resuscitation success if you live 30 days after discharge from the hospital. And that's how we report it to you. There's a 10% chance if it's a witnessed arrest. There's a 5% chance if it's not. Most doctors are sophisticated enough to tell you that and go on, well, if you're older, it might not be as good. But why don't we just tell you that? That you have consequences even if you survive, that the quality of your life may not be what you think. How many people think Terry Schiavo is a resuscitation success? Why would we report it to you that way then? That's a research endpoint, not a humanitarian endpoint. So what we learned from Terry Schiavo is it's not just about reporting information accurately, is that disease doesn't exist in isolation. I mean, there was huge legal issues in the state of Florida about her feeding tube with her husband and with her family and all of the emotional distress associated with that because there was not full disclosure of the consequences of care. We also learned that the metrics that we're using in healthcare, they're important. Of course I want to know whether you have a stroke or heart attack or a bleed. You want to know that. But what is it? It's not enough. Our metrics, since even up to today, are not enough when we evaluate research when you go into your doctors or hospitals to decide how well you're going to do when you're discharged. Here's another example. So our metrics are not enough, but what about feeding tubes? And many of you may have seen family members or gone through this. We know that feeding tubes in the advanced elderly, especially in demented patients, because of the changes in physiology to the body, because it cannot metabolize nutrition now. These feeding tubes either do nothing, or they increase pneumonias, increase pressure ulcers, do not improve the biochemical markers of malnutrition, they increase suffering, and the patient dies quicker. What's the metric that most people get excited about when they put a feeding tube into their loved one? Weight gain. The weight they're gaining is the isocal or nutrition that we're stuffing their intestines, but it's not meaningful weight gain. So not only are we not measuring enough metrics, sometimes we're measuring the wrong metrics. And we get excited about weight gain when weight gain was never really the issue, was that nutrition being used to a purposeful conclusion? And it never was. And so we've stopped using feeding tubes, and it's still very hard because some family members are emotionally distraught about the fact their loved one's starving, and in fact the body's actually shutting itself off so it can't metabolize that nutrition. And that's a hard thing to deal with. So if we're going to move forward with good health care, it's not only going to be the physicians and healthcare industry that has to do a better job. It's going to have to be society understanding why we make these changes. But we're going to have to expand our research metrics, and we're going to have to evaluate metrics that do not, or eliminate metrics that do not provide value. So expand the metrics and eliminate metrics that are not valuable. We have to give full disclosure of not only the short-term outcomes, we got you over your hip fracture, your pneumonia, but the long-term consequences of our care. And we're going to have to use evidence-based knowledge, not guessing, not hopeful care, but evidence-based knowledge. These are very difficult questions because doctors, nurses, hospitals, we're all human beings too. And I'm constantly asking myself this question when I offer a treatment to my patient because I feel the need to do something. Doctor, please do something. But doctors feel that internally, I have to do something. Well, who am I treating? What if I do something that's not actually helpful, but I feel good because I treated them? It's not the treatment act that matters, it's what it achieves. And many people that I work with would agree that the advanced elderly are massively overtreated in this country, and even to a harmful extent. And how do we address the moral resolution of healthcare providers and families when we're talking about what is the right thing to do? So what I'm talking about now here is geropalliative medicine. How do you deal with the existential, the physical needs, the emotional needs about values that you have for yourselves? If you accept the risk, I'm fine, but you need to know what those risks are, because it's not just about treating the organ system, it's treating the human being behind that system. So this is my version that I wrote up for Sharp's view of what palliative medicine is, and we all know about hospice, and then we developed inpatient palliative medicine. At Sharp, we have the premier community-based palliative program in the country, but then you have all sorts of great traditional providers moving medicine this way. We're moving medicine this way, and there's this big gap in here. And I kind of heard it said over here, I'm not about dying, I'm about living well till the very end. And how do we fill that gap in with the best information so people can make the best choices about what you value most? Now, you can't get away from certain things. It's just not going to happen. Your body will get older, whether you like it or not. Next year, your kidneys will not work as well as they did this year. And for some of you, if you live long enough, that would lead to the option of choosing dialysis. But most of us aren't going to get there, but our kidneys will not work the same as they did last year. Our heart won't work the same, our lungs, guess what, won't work the same as well. Our physical function and our minds. But what do people care about most, especially the advanced elderly? Keeping their cognition intact. That has been proven repeatedly in the healthcare literature. So our goal for our patients, and as you saw that on that gray bar, just like with children, should be to anticipate the inevitable consequences of the natural progression of illness and to understand the unintended consequences of well-intended care, and by proactive management, guide our decision-making in the context of that care. So this is a graph I'd like to show. I started in the 80s. In the 80s, if you came into my hospital, as all hospitals around the country, you didn't have a choice. You got what we gave you. And what happened in 1990, 1991? Where's our attorney? The Patient Self-Determination Act. Patients have the right to say no. Doesn't mean it was automatically respected. That's a legal change. Culture change takes a lot longer. But in that time, you were able to actually make a decision about resuscitation and what you would want. Very, very difficult changes. But at the time as well, people didn't live that long. I was excited. I started in the 80s. When my patients made it to age 75, I was really happy because most of them died in their early 70s. And God forbid if I got them to 80, that was great. Nowadays, in my practice, I have a parade of 90-year-olds doing well. Anybody remember what pneumonia used to be called? The old man's friend, yeah. You got pneumonia, that was it. A third of people who had heart attacks died. That was it. First one, done. You know, a lot of the healthcare we had, you hit the end, we didn't have things we could do, you didn't make it past. Nowadays, we finished the bell curve. But it's that red circle that's still like the deep blue sea. We don't know what's underneath there and how to manage this segment yet. I mean, I'm going to read something to you that'll prove my point. This is a research article out of the Journal of American Geriatric Society. It was published by the American Heart Association, the American College of Cardiologists, and the American Geriatric Society. And it's about knowledge gaps in cardiovascular care in older adults, a scientific statement from the AHA, the American College of Cardiologists, and the American Geriatric Society, an executive summary. This was published only 3 years ago. And what it says is the incidence and prevalence of most cardiovascular disorders increase with age, and cardiovascular disease is the leading cause of death and major disability in adults older, age 75 years of age and older. Despite the effect of cardiovascular disease on quality of life, morbidity, and mortality in older adults, individuals age 75, and listen closely, individuals age 75 and older have been markedly underrepresented in most cardiovascular trials, and virtually all trials have excluded older adults with complex comorbidities, significant physical or cognitive disabilities, frailty, or residence in nursing homes or assisted living facilities. I see those patients every single day in my practice. Every single day, that's the majority of the patients I see, but they were excluded from research. The article goes on to say, as a result, current guidelines are unable to provide evidence-based recommendations for diagnosis and treatment of older adults typical of those encountered in routine clinical practice. What did the American Heart Association just say? We don't know what we're doing yet. I am actually proud, because I've spent my entire career in that red circle, and I was aware of this. Every time you go and do a research evaluation of what am I supposed to do for my 80-year-old nursing home or assisted living or somebody with complex comorbidity patient, they were excluded from research. Why did we do that? It was the right thing to do, because when you're younger and healthier, we want to know how to treat you properly, and most people in the 1980s weren't living into their 80s and 90s. We excluded you from research because you skew the results for the body of the patient population that we treat. And we've done a great job getting people to be older with coexisting conditions. The problem is we now have to go back and see what we've done because everybody's living so long. The age groups that are growing the most rapidly are 75, 85, and older. And there will be millions of us. Anybody know what percentage of patients will be over the age of 65 by 2025? 20% of the population, just under 20% of the population will be over the age of 65 in just a few years. So I want to go on and read this too, because this is the part as the palliative provider that knocked me off my chair. There's a pervasive lack of evidence to guide clinical decision-making in older adults with cardiovascular disease, this was found, as well as a paucity of data on the effects of diagnostic and therapeutic interventions on outcomes that are particularly important to older adults, such as quality of life, physical function, and the maintenance of independence. And it goes on to talk about the effects of cardiovascular care on cognition and how many patients were actually damaging your brains. That's the future, and that's where we're at. I'm going to tell you something I normally tell to providers. There was an article just published. Canadian researchers looked at it was 26,000 randomized control trials from 2005 to 2015. Randomized control trials are the best research to tell us what to do for people when we're doing clinical trials. And they went back and they said, well, let's see how many of those trials are for people age 55, 65, and 75 years of age and older. And what did they find? At the age of 55, only 6% of randomized control trials were for that age group, 55 years of age and older. If you're 65 years of age and older, raise your hand if you're under 65 in this group. Okay? If you're 65 years of age and older, 2% of randomized control trials tell me as a physician what to do for you. And if you're 75 years of age and older, 0.1% of randomized control trials tell us what the best medical care is for you. That's the state of affairs in healthcare. It's not a bad thing from the 10,000-foot level. It means we're keeping people alive longer. But I would encourage you and challenge you to ask your doctors, is this recommendation based on medical evidence for me? And it's not bad, and it doesn't mean there's not other research. It's just that the best trials, they excluded many older folks with comorbidities. And we have to go back, and we are, and the American Heart Association has owned up to that and said, let's move forward and do a better job. And there are other professional societies doing that too. But for your sake, you should know it's only happening now. It hasn't been something that's been the standard of care for the 30 years, 35 years I've been in healthcare. Sorry, I didn't mean to perseverate on this slide, but it's a big deal. So what do you need to do? When you get older, to protect yourself from the unintended consequences of a well-intended care, your physician and you need to be looking at the domains that put you at risk. Older folks tend to do worse. If you have a low or super high body mass index, if you have depression or other comorbidities, those things are general information we should know. Your disease burden, how many other illnesses do you have? Have you ever had a pressure ulcer? What do your laboratories look like? Have you ever had delirium in the hospital? Those things tell you significant information about your risk. Medications and lifestyle. Do you smoke? Do you drink? Do you have polypharmacy? Anybody know how many pills it takes to get the diagnosis of polypharmacy? 6. 6. It's a risk factor if you're on 6 or more pills. And as you get older, that's because your ability to metabolize these pills, whether you like it or not, changes. Your blood flow to your liver drops by 40%. Your kidneys do not excrete those medications as well. Your protein binding, the ability of medicines to be free medicines versus bound medicines, there's lots of changes that go on. And you need to know this information so you can make good choices. We need to know your functional status, your cognitive status, and do you have anything called a geriatric syndrome? So why should we do this evaluation, and why should all doctors? So I give this talk to doctors. I have not changed the slides. This is the same talk I give to slides. I just changed the vernacular a little bit. It's because uninformed treatment, in my mind, is mistreatment. And in many cases, overtreatment can be deadly, and we just don't realize that. So that's me on the left. My wife is Thai. I happen to have been chosen by her Thai Buddhist temple to be the physician for their temple, because I'm willing to accept people's alternative pathways in life and be respectful to their decision making. Because to me, it's not about my decision. I'm only here to be a guide. They can choose the pathway. We just put it before them. But Buddhism has a philosophy that virtually every other religion has, and every other ethical philosophy has, and I like to quote it. It's called the principle of right speech. And in the principle of right speech, you have a moral obligation to share information with somebody if it would change the decision they would make, even if that decision is different than the one that you would choose for yourself. So as a physician, I have to give information to you, even if you would say no to the procedure I would recommend. And the other part of the principle of right speech is you need to do it kindly, and you need to do it in a timely manner. The time to tell a patient that they could have permanent cognitive damage is not when they're being rolled into the operating room or in the pre-op room. It's weeks before the procedure. To say there is a risk that if you go for this procedure, you will come out with probably a perfect knee or hip or heart or gallbladder removal or whatever, but you may suffer some cognitive damage. Just off the top of your heads, how many people, what percentage of people will have statistically significant decrease in their cognition if you're over the age of 60 at 1 year, if you go for a coronary artery bypass graft or an open valve replacement? Anybody know? 20%. 20% of people that go for coronary artery bypass grafting, and a third if you develop delirium, will have statistically significant declines in your mental status at 1 year. And if you look at those articles that have ranged from 3 months to 5 years, 40% of people will never return to their previous level of cognitive function. How many of you have been aware or warned that when you go for a procedure, you could have permanent cognitive damage? Now you're warned. So that's my soapbox. Pretty good soapbox, I hope. And I'm going to move on to real patients. This is my patient, Josephina. I've added a few educational points in here, but it's close enough to the real story. Where do I need to point? Do I point at you? Oh, it worked. So, 80-year-old female, spinal stenosis, comes into your office complaining of radicular pain. That means pain shooting down her leg. She's moved in with her daughter to help manage her IADLs. IADLs are, check paying and cooking and house cleaning. She's independent in all of her ADLs, but bathes twice a week and uses a shower chair. ADLs are bathing, dressing, grooming, toileting, transferring, and feeding. And when a patient says, I don't have any problems with bathing, but I only take a shower twice a week and I have a shower chair, they actually do have a deficiency. A lot of people don't want to admit deficiencies, so I'm telling you, speak up and say, I have a deficiency. She's fallen twice in 6 months. She doesn't meet the phenotypic criteria for frailty. Her daughter states that she's just not as strong as she used to be and can't open jars. She uses handrails to pull herself upstairs and now for balance. She has COPD, heart disease, depression, insomnia, and osteoarthritis. Those are her medications up there. Those are her vital signs. Her exam is normal. She has a little bit of muscle wasting. You can start to see that in her face. She has decreased grip strength, mildly decreased air exchange. Her lungs are otherwise clear. Her heart is fine. She has no neurologic deficits except she has a foot drop, meaning she drags her foot. She can't lift her foot up because of the pain and because, sorry, thank you for pointing that out, because of the pain and because of her foot dragging down, being pinched in her spine. Her labs are normal. By the way, is that a good cholesterol when you're older? 232? Yes, thank you for those of you who said yes. If you have primary hypercholesterolemia, it's a little bit technical, and I'm glad people's mouths are opening. There is a significant amount of information that if you are, not if you have heart disease, diabetes, or any other reason to treat it, but if you're just treating a number per millimole increase, that's 39 milligrams of cholesterol above 160, there is a 15% decrease in mortality. I said there's decrease in mortality with higher cholesterol. I'm not going to get into why that is today. And don't go stopping your statins or your other medicine until you talk to your doctors. But this is the information that's coming out in that red circle that we never knew before. Low cholesterols in the elderly prognosticate death, infections, cancers, and pressure ulcers. So be careful what you agree to or what you treat when you get older. Lungs are clear, EKG is normal, timed up and go test is 19 seconds. How many of you have had your doctor check your walking speed before you go for surgery? According to the National Surgical Quality Improvement Program, 2012, 2016, and this year, we should all be doing frailty and cognitive evaluations before surgery if you're 70 years of age and older. Everybody. MMSE was 23. How many people are getting cognitive evaluations before surgery to get a baseline? Also in the recommendations. Every one of us. The answer is most of them. I will repeat the question. What's the likelihood that your doctor, if you ask them, would know what to or do? Healthcare education. And like I said, this is new to everybody. So it's going to take a little while until it's integrated, but you can ask for those tests and say, I would like to have my cognition and general functional ability and a frailty evaluation done before you make a recommendation to me about what I should do for surgery. And if you don't know how to do it, consult Nick. And he'll help you. Palliative physicians do know how to do this. Consult a physician, say, I would like to get a general palliative consultation or a palliative consultation, and they will give you a hand. They're available now. As a matter of fact, San Diego has plenty of providers that can do a palliative consultation for you. Okay. Can you hear this? Is it working? Here we go. All right. So the daughter states her mother would be better if she didn't have sciatica and the patient was just in the hospital due to a fall from her foot drop. And she was told that, quote, I get this as a primary care physician all the time, they told me I had to have surgery. Let's see, she asked specifically about surgery and states that she's heard bad things about being on opioids. You notice she was on Vicodin 3 times a day. Non-surgical interventions have otherwise had limited benefits. And what can you tell them, and what are her unique risks? And what do you tell them? Oop. It's a slow pointer. So you use the 6th domain. She's older. She has a little bit of cognitive deficit. She has polypharmacy. There's some of the medicines she's are on, they're called anticholinergic medicines, put her at greater risk. She has some functional decline. She's losing her strength. And she actually has something called a geriatric syndrome. And those geriatric syndromes dramatically increase her risk of poor outcomes. So when your doctor says, you've got a 20% chance of this or a 4% chance of this, that should not be enough. We should be able to use our skills to say, well, this patient's more likely to be that person, 4% or the 20% risk. Does that make sense? Can we pick out somebody who's higher risk than just 100 people coming into a room? And the answer is yes. Sorry about the delay. It's confusing me. There we go. So, this is a very common problem, sarcopenia. Anybody heard of that word? Who's heard of sarcopenia? Excellent. So, what is sarcopenia? You forgot, okay. Sarcopenia is the loss of muscle being replaced by fat tissue. Starting at the age of 30, you're all losing, well, I'm blaming it on you. You're losing it, not me. Yeah. We are all losing muscle. It's not a choice. It's physiology. It's just what happens when you get older, like your kidneys getting weaker. You are losing about 1/2 pound of muscle per year, and you're gaining almost 1 pound of fat. We all know that. That's what's happened to our physiology over life. But that fat tissue has a unique purpose, as does the muscle tissue. You probably never heard of this. Your fat tissue is an endocrine organ. It's actually secreting hormones, inflammatory cytokines that are trying to shut you down. And your muscle tissue is secreting hormones trying to keep you alive. And doctors have known that exercise is good for you since the beginning of time. And that's why we continue to recommend it, no matter if you're bound in a wheelchair or you've got severe arthritis in your hips and knees. We tell you to keep exercising because you will do better, and that has been proven over and over and over. My favorite patient's a guy named Henry Sang. Anybody know about him? 112 years old. I saw him on a video. He died at 112. At 111, they had a picture of him getting out of his wheelchair onto the exercise bike at the Austin, Texas 24-hour fitness. He'd been exercising his entire life. And his fat to lean body ratio was keeping him alive and doing well. He was living independently and well past 100 years of age because he took ownership of his health early. But frailty is another syndrome. Cachexia is another syndrome. Sarcopenia, half of people over the age of 80 are sarcopenic, and we don't ever talk about it. It's incredibly important to know whether you're sarcopenic, and I keep encouraging my own medical group to get body composition scales. If you ever have a chance to get your body composition, you should do it, because that will tell you what your risk profile is. How much muscle do you have compared to fat? That's the difference between a sarcopenic patient and somebody who's not. This is looking at their leg. If I had I was going to put a CAT scan up here, but I just put an image. If you took a CAT scan and did it across the middle of their thigh, you can see that the thigh looks exactly the same as it did 20 years ago, but this is what's going on inside. You're losing muscle and you're gaining fat. That's called sarcopenia. Why do we care about sarcopenia? Because when you're older, sarcopenia increases your risk of infections, pressure ulcers, loss of autonomy, can't do things on your own anymore, institutionalization. How many people want to be institutionalized? Raise your hands. Okay. decreased quality of life if you have a hospitalization or intervention, and mortality, raises your risk of dying. In particular, this patient was going to be recommended for spinal surgery. Incredibly risky procedure in an 80-year-old. She was 80 at the time. And I told her, well, you can, but you probably have not been told this information. You'll be in the hospital twice as long, which is bad enough because when an elderly person lies flat in bed, you will lose 5% of your muscle strength per day. When you're younger and healthier, it's 1 to 1.5%. So you've all seen people go into the hospital, they're lying in bed for days, and they never come back functionally the same person. She's twice as likely to be institutionalized, and it was pretty high level anyways, but now it's 82%, 81%. And 300% increased risk of having complications. Did we just tell you who that 4%, that 20% risk was when the doctor says you got a 20% risk with 100 people? Yes, we identified that this was the high-risk patient. She has other indications that she wouldn't do well. She has deficiencies in IADL, decreased cognition, and age. This was a prognostic model done by Mark Sager, a prognostic model. And this says that 55% of patients who go in the hospital with these criteria will come out with some level of functional deficiency. So I can't tell you whether you're going to be suddenly incontinent of urine, whether you're going to have a slower walking speed, whether you're going to lose an ADL, but there will be some level of functional deterioration just because of the effects of being in the hospital. The timed up and go test, which we should all be doing, and functional dependence, is the worst predictor of you being institutionalized after you go to the hospital. And just looking at her medication list, you could say she's probably going to have a longer functional walking speed, timed up and go test. Her medications, greatest risk for delirium, the #1 side effect of hospitalization for the elderly and functional decline is polypharmacy, 6 or more medications. Delirium's that confusional state when you get in the hospital and you're disoriented. And I'll tell you a statistic I don't normally give with this talk, but I'm going to tell it today. Hospital-induced delirium in the elderly increases your risk of being diagnosed with dementia by 12.5 times in the next 4 years after you're discharged. Patients with cognitive impairment. She had a decreased MMSE score. She was right on the border and it was early, but most doctors don't pick that up because it's early and they can still communicate with their doctors. They don't appear to be cognitively dysfunctional. And they don't do the testing, which we've proven once again in here. But they're 500% more likely to develop the most common side effect of hospitalization for the elderly. In the past, the way I was trained originally, we used to think that delirium was a temporary side effect. And we have to go around the country now saying, no, it's not a temporary side effect. It's associated with permanent cognitive damage. So if we decided to take her to surgery, which is, we talked about this, I talked to her and her family, I said, what's important to you? And she said, what's important to me is to keep my cognition where it is, to stay in my apartment. She was living next to her son previously, and now she was living with the daughter. And I said, well, if you value those things, going for surgery may not be in your best interest. You're kind of, we call it furniture surfing, getting around the house. You enjoy having your grandchildren go over to meet and talk with you. We can fix your spine and take away the impingement, the spinal stenosis, and your foot drop will probably go away, but the cost may be worse than you've been told, even though you were told you had to have surgery. And she decided she did not want to have surgery. I said, that's totally fine. Now, if you decided you had surgery, we would have done many things. We would have cut down on many of her pills. We would have lowered her anticholinergic burden score. We would have started education about exercising and dietary changes before surgery, and we would have recommended melatonin, not for sleep, for delirium prevention. And we would have considered perioperative antipsychotics, and we would be absolutely sure as palliative providers that the patient and family understood the unintended consequences of the care they were going to receive. Now, before we go to the next patient, I want to tell you this. That patient that you saw, I saw her last year, and I looked at her and I said, hey, why aren't you wearing your foot orthotic, the little brace that keeps your foot up when you have a foot drop? And she'd been on 3 Vicodin for 5 years, controlled her pain perfectly. But when I asked about the orthotic, she said, oh, Dr. Hoefer, my foot drop's gone away. That's not supposed to happen. She got better. Going from you have to have surgery to your foot drop going away. Suddenly she didn't have to have surgery. As a matter of fact, she never had to have surgery. If anybody says you have to do something, think twice. There's 2 things I always tell the people. If anybody says there's no side effects, get away, get up, walk away. There's always side effects. It's not possible not to have side effects. And if anybody says you have to do something, you don't have to do anything. You have to listen and accept the risk, because there's always risk and benefit in everything we do in healthcare. Okay, maybe the battery's getting weak. Yeah, okay. It didn't work this time. I'm not sure. Let's see. There we go. There's another study. So I'm going to do another one. It's an 83-year-old male. Severe frailty, declining health, comes to your office, severe pedal edema, swelling in his legs. He's cognitively intact. Can he communicate like the people in this room? Yeah. He can communicate like the people in this room. He moves from room to room with his front wheel walker. His echocardiogram for the swelling showed moderately severe aortic stenosis. He was referred by his primary care physician to cardiology for a possible procedure. He sleeps in his recliner to help him breathe easier. That's his medical problems: diabetes with a little bit of kidney disease, coronary artery disease, and enlarged prostate. He has a little bit of what we call mild dysplasia, a condition that makes him anemic. He gets Epogen, which is a medicine that raises his blood level. Those are his medications. Let's see, 1, 2, 3, 4, 5, 6, 7 medicines. His body mass index is 21. That's a little bit low for an older person. He has a lot of swelling in his legs. He has an ulcer that's healing. And his labs are normal, but his total cholesterol is 68. He's somewhat cachectic appearing. Is 68 good? No, it's atrocious. Oh, now it's super sensitive. And this is the story of my father. So, this is my dad going through this procedure. This is about a 4-year process. But I'll ask you something. If you look at those pictures, in which picture do you think my father is frail? There's only one correct answer. And the correct answer is, under no circumstances can you look at somebody and know if they're frail. You cannot look at a patient and know if they're frail. You have to do a professional evaluation. It's more likely he's frail in the second and third pictures. But my father was frail in all 3 of these pictures. And his doctors didn't know what that meant. And that's unfortunate. We were learning about frailty syndrome more, and we have to learn the consequences of operating and treating frail patients. The reason I know he was frail, I've always tried not to be my family's doctor. There's too much emotionalism in between there. But he was losing weight. This is one of the phenotypic characteristics. My mom would go on walks with him, and he suddenly slowed down, and she'd tell me, I don't know what's wrong with Dad, but he's not walking the way he used to. He hired a personal trainer at the age of 80 because he recognized that he was getting weaker. He got extremely exhausted, and that's a picture from the last flight he ever took. That little bars from our Cessna out of Gillespie over here. My father was a commanding officer in the Navy, and he flew for United Airlines. But he went on that flight, and he said, I'll never do it again. He was so exhausted from that little trip out to Anza Borrego. And his activities had decreased. He was a very interactive person, and that all was slowing down and stopping. That was the frailty process starting. His pro-inflammatory cytokines rising, his anti-inflammatory cytokines dropping, and the process of turning him off was beginning. Okay, it's probably on a delay. Maybe it's got a coronavirus in it or something, no. So a patient, so my dad got a palliative consultation. Oops, that is really weird. Palliative consultation, and they come in and ask you about the risks of surgery and medical management, and what could you tell him? And the answer is always refer to the risk domains. He's older, he's male, he was not depressed, he had a good BMI, maybe a little bit low for his age, but not severe. He had a sacral ulcer. That is a bad sign. If you have an ulcer, a patient with an ulcer on their body, especially a heel ulcer, that's a bad prognostic sign. Be cautious what you agree to. He had polypharmacies. He had 7 or more medications. He was completely cognitively intact, which confuses doctors. They all acknowledge this, and nurses as well. If you have a patient who's cognitively intact, we think they're fine. Make sure they get an evaluation. Make sure you get an evaluation. He was functionally declined, and he was completely deficient in his ADLs and IADLs. That was the middle picture. You couldn't even do a timed up and go test, and he had every characteristics of frailty. They were obvious by the time he was being referred because of the swelling. Now the swelling occurred, he got referred because of me. I regret it to this day. I drove up to Mission Viejo, and I'm sitting in the patio with my family, and my dad's there. My wife and I would go up once or twice a month and visit. And I looked at my dad's legs, and I said, "Hey, Dad, your legs are really swollen. Why don't you go talk to your doctor about getting on a diuretic or doing something to see if we could help you out?" And the doctor did a perfect traditional evaluation for that younger and healthier population. And I hadn't even gone back, and he'd been referred to his cardiologist, and they found out he had moderately severe aortic stenosis, a valve problem. Look at that. What happens when doctors see something they can fix? Their eyes get big. We can do it. We got all these new treatments. It's really cool. These new TAVRs, or you can have open surgery if you're younger and healthier. But what I could tell him, which is I ended up having to do with my family, is it was at significant risk of functional and cognitive damage if he went for these procedures. That's not maybe. We know this from the medical research that's coming out. So I have to tell you, I went up to see my dad, and he got referred to his cardiologist, and I said, hey, Dad, in the context of your frailty, what did your cardiologist tell you? My dad was a CO. He did not have a problem telling you what he meant. But this time he was kind of mumbling and wasn't really clear because his doctor did not tell him what the procedure that they were talking about, either a valvuloplasty or a TAVR, would mean in the context of his frailty. I asked permission to call his cardiologist, which he gave me. I called him. Cardiologist was great. I'd have surgery by the guy. And it's not the cardiologist's fault. He just didn't know this information yet. But I asked him twice, in the context of my father's frailty, what do the outcome metrics look like? And so he went through them and from what he thought he knew, and this article actually came out after that, and he said, might have to go through the apex of the heart. There's a 14% chance of stroke, and said all this other stuff. I thanked him very much. I drove home immediately to San Diego and got on the phone with another cardiologist that I work with. Wasn't any better. But I learned later that they were referring to a research article such as this that shows what happens with frail patients when you take them to surgery, even for transaortic valvular replacement. And look at that. What do we have down here? 30-day mortality, life-threatening bleeding, major threatening bleeding, intravascular vascular complications, kidney injuries, stroke, 1-year mortality. Pretty much the same except for the 1-year mortality. But what's wrong with this research? This is a brand new procedure, and this article was published in 2012. What is wrong with this research, standard of care research in this country? How many people are in the study? Not it. Age of the population, not it. Where's the patient-centered quality metrics about the decline in cognition and function? Do you care if you go for a TAVR and lose cognition? If you don't care, we don't need to try doing this research. You don't need to hear what I'm saying. If you do care, we need to recognize that research metrics are inadequate and they're not addressing the two things patients care about most.
So I ask you this, are we presenting information to our patients any differently when we talk about TAVR, cancer treatments, treatment in the hospital for pneumonia, any differently than the way we treat representing information about surviving a cardiac arrest? It's all about the organ systems. It's not about the human being around the organ system. Did you come out the way you went in, and did we fix the problem? Who said that? It was you. We don't do research to answer your question yet. Although there are providers that are growing in popularity and tiny number, we need more of them, a lot more, who would be able to help answer that question for you. I personally find it profound that the two things that the advanced geriatric population cares about most are the two things that the healthcare industry evaluates least: function and cognition. And you can look at any research article and you'll validate what I just said. We are not looking at the things that the advanced geriatric population cares about most. Why? Because we excluded you from research in the past. And we looked at younger and healthier patients that had the ability to recover. But now we're treating people that don't have the physiologic and cognitive reserve to recover, and you better be careful what you agree to. You know what's analogous to? I think it's exactly analogous to. Has anybody heard of chronic traumatic encephalopathy? Football players getting hit in the head and finally having permanent cognitive damage down the road. How many hits to the head can a football player have before they have permanent cognitive damage? Now, I don't know, somebody yelled out in an audience 6, and I said, okay, good, I'll go with that. But your body can only tolerate so many hits before your organ systems don't have the ability to recover. Your heart, your lungs, your kidneys, your brain, your muscles. And so there's a lot you can do to take care of yourself to have more reserve, but at some point you probably want to think like Josephina and say, no, I'm pretty happy where I'm at. I'll just take my Vicodin, and God forbid, her foot drop even went away. Now, my father agreed to go to the procedure, and I was fine, but I had to sit down with my family. And I called my parents up. I did not want to be their doctor. Put my sister on the phone. My brothers were around me. I said, your doctors are really good, but here's the part they were not trained to tell you about. You have significant risk of cognitive and functional damage. If you go ahead with this, it's okay, it's your choice, but I want to be sure that you understand that. My father decided to go ahead with the procedure, and so he went into the hospital. He had a valvuloplasty, which is even less invasive than a TAVR. And the valvuloplasty went perfectly. His aortic gradient, the blockage in his aortic valve improved significantly. All of that fluid came off of his legs. But you could see then, you didn't need to be a professional to know he had frailty. It was paper-thin skin, tissue paper skin on bones. We did a thoracentesis, took a little bit of fluid out of his lungs. We gave him his epigen, and his hemoglobin went from 9.4 to 10.6, so that improved. But as predicted by prognostic modeling, he never walked again. He lost the autonomy to walk from room to room with his front wheel walker. That was the price of the procedure. But that wasn't the only price to the procedure. Prognostic modeling also said he could have significant cognitive damage. And he did. He was delirious for 6 weeks, so delirious we put him on hospice because he couldn't even talk to us. And every family member will tell you the same thing. He was lucid for brief periods and could have a conversation, but the rest of his life, most of it was like the third picture. And we would ask, are you listening? And he'd say once in a while, yes. But he was not communicating with us. That's the difference between coming out the way you went in and fixing the problem. There's more to that tragedy. Please. Delirium's an acute confusional state where it kind of comes and goes. You're disoriented, sudden onset, tends to fluctuate. There's more clinical signs to that. But that's basically what delirium is. Anybody seen their loved one go in the hospital and get confused? That's delirium. Okay. But I want to tell you, the rest of this story is, it makes me profoundly upset, or not upset, but enthusiastic to change healthcare, is that my father's outcome, because his aortic gradient improved, he did not have a stroke, he did not have a bleed, he did not have kidney damage. My father's outcome would be reported as what? A perfect outcome. I want to show you something you may not know. This is severe aortic stenosis. You don't have to read the gobbledygook, I'll just tell you, is that the mortality rate for untreated aortic stenosis is about 40 to 50% at 2 years. But the mortality rate for delirium is 40 to 60% at 2 years. Because he developed delirium, he was at higher risk of dying than had he just not treated the valve in the first place. I will show you. This is 2019. I told you things are changing. People are trying to get better. This is looking at surgical aortic valve replacement and transaortic valve replacement, 55% and 25%. The problem when you develop delirium with TAVR, you're probably more susceptible. That's why you got that procedure. So if you do become delirious, outcomes tend to be worse. Yep. There's a real delay on this. So what's the moral resolution to healthcare providers? If we don't understand or recognize the patient-centered consequences of our care, how can we advise the patient against care? We can't. We have to expand our metrics when we do research. We have to do it. This demographic does not have the physiologic or cognitive reserve. It's called your stem cell-mediated regeneration to go back to the way you were, even if you fixed the problem you went in for. I hear this all the time. It says, you know, a patient comes in and says, if we don't do something, my dad's going to be dead in a year. What's wrong with that? If we do something, his quality of life may be so poor, he wished he was dead. And I talk to providers about this all the time. We have to recognize these geriatric syndromes because it will be the future of healthcare. If you take a frail patient and they're on the edge of the cliff, does it matter whether you shove them over with a major intervention or just nudge them over with a minor procedure? They still hit the bottom of the valley the same. Not a good outcome. So I actually told you what happened already. My father died 9 months later, significantly less than the average person who went with an untreated aortic valve. I cannot guarantee you that the procedure did not accelerate his death, even though the procedure was reported as a perfect outcome. But that's because we don't measure patient-centered quality metrics of cognition and frailty yet. I'm just going to bring this full circle. This is from Hippocratic physicians. In the 80s, we stopped teaching prognostication. We focused on diagnosis and treatment. But this was Hippocratic physicians. It is the most excellent thing for a physician to cultivate prognosis, for by foreseeing and foretelling the present, the past, and the future, and explaining the omissions which patients have been guilty of, he or she will be more readily believed to be acquainted with the circumstances of the sick, so that men and women will have the confidence to entrust themselves to such a physician. Isn't that the doctor you want? Yeah. So anybody know who that person is on the left? Can you tell that's me on the right? Who's that on the left? Atul Gawande. Anybody read Atul Gawande's book? What'd you think? What did he leave out? No surgery at all. The option of no surgery. He went from an immediate, more aggressive surgery to a delayed, lesser surgery. That's me telling him, what about no surgery? I said, for your next book, add this piece of the equation into your story. Look at his face. Yikes. That was a book signing. It'll be on the web, yeah. There's another book, this is by Katie Butler. I and many other physicians that work in this arena are in here. And I don't like the title of this, it's The Art of Dying Well. I would prefer, had she said, it's The Art of Living Well Until the Day You Die. That would have been a better title to me, because that's what I do. But you can learn a lot from this book. And that's for physicians, just showing that frailty is a lot more risky no matter what you do in cardiology. Yep. And I'm just going to go ahead and stop there. I can't get this thing to cooperate with me. So I hope that was informative and helpful. You can decide your own paths and work with your doctors. Don't go and stop all your meds. And don't go and be mad at your doctors. We cannot know everything in healthcare. And your doctors are working their butts off to learn as much as they can. That will do the evaluation. So what I was going to say is don't get mad at your doctors. They're working their butts off to do the best they can. I do not know everything about oncology or cardiology. I am a geropalliative physician. I know about this segment of the population. We work together as teams. This is very, very new information. So work with them and say, I just want somebody to do a cognitive evaluation, and I want you, if you can, to tell me what my cognitive risk if I have this medication, this intervention, this procedure, as you move forward. Yes, ma'am.
Rather than just saying, how risky is this procedure, Doc, are there specific questions that you can ask in the process to help you with that decision?
Yeah, so the answer that she was asking, what questions can you ask to understand the procedure you're undergoing about the risks? And I would say always talk about the risks and the benefits, because you're going to have to balance that out. Be aware that we do not historically evaluate cognition and general functional ability. Just be aware of that. Ask them to do a timed up and go test or a frailty evaluation, and don't let them look at you and say you're frail or not. Do a professional evaluation. If they don't know how to do it, ask to be referred to somebody who does. It's the best thing you can do. And ask, what can you do to protect my mind? There are many things that can be done. We're actually doing those at Memorial. We're integrating all of these at Memorial. We're working on Grossmont now, and we're working on national education. So I'm actually developing a education module for physicians with CAPC, the Coalition for the Advancement of Palliative Care. That module will be done soon. It will be a national tool that people can use to educate them, physicians can use to educate themselves. So times are changing. It's just you're in the middle of it. Yes, ma'am.
But people have the mic, Dr. Hoefer, so she has.
Oh, sorry. I apologize.
If someone is going for surgery, they should also prepare their material with anesthesia.
Yeah, well, anesthesia is a great question. That's a real tricky one. There are some anesthetics that don't cause as much delirium. You could ask for one of those. You could risk be putting into less deep anesthesia, but once in a while, you're aware of what's going on. You're protecting your brain for the incredible fear of watching the surgeon cut into your belly or wherever they're cutting. I told you there's no risk. If anybody says there's no risk, walk away. It's hard to know the precise thing to do, but you need to be a part of that decision. Sorry, somebody who has the mic. Oh, there we go.
I think it's really important for people to understand about the research studies that are going on, but I don't know of any research study that is going on right here. I had cancer in 1982 and went into a research study for chemo and learned a lot from it. And some of the chemo that I had then is still being used right now. So what we need to know, because I'm willing to go into a research program, where are they? How do you get in touch? What can we do?
So if you want to get involved in research studies, especially cancer research studies, you need to talk to your oncologist. If you usually won't get into a research study until you've failed traditional lines of research and they're looking for an alternative therapy. For this, okay, well, it's being developed. I am a family physician who worked in this area because I've worked in post-acute care. I am not a researcher. Just telling you that. I did this because I saw my patients being harmed, not maliciously, unintended consequences of well-intended care. That's what I call it. Everybody thought they were doing and agreeing to the right things. It turns out they didn't understand the long-term consequences. But those of us who spent most of our careers, 35 years, in post-acute care, we saw that damage. And so we're bringing it back to the forefront, and now that's starting. You could call UCSD, you can call CAPC and say what research is going on. But I'm telling you, this is cutting edge. It's very, very beginning. So, yes, ma'am. Wait, am I supposed to wait for the mic to get to somebody? Oh.
Hello. Hello. I've had the privilege of listening to you several times at Sharp. I have a question about the melatonin and the preventative for the delirium. Can you tell us more about that and if it's something that we can do over the counter?
So the answer is the melatonin studies are very limited, but the few that have been out, we always like it when there's 20, 30, 40, 50 studies. There's a few studies that have shown that when you take melatonin or perioperative melatonin, that will decrease your risk of hospital-induced delirium. The numbers are actually rather profound. I think it drops from 33% down to 13%. There's another medication called Romaltion. I'm sorry, I'm going to give a brand name. This isn't a CME, so I guess it's called Rosera. It's even better. That's the one with the commercial about sleeping with Abraham Lincoln and the porcupine. Remember that one? But don't use it for sleep. It's not for sleep. It's to protect you, give you cognitive protection if you go in the hospital. And I've talked to our trauma surgeon. She's using it over at Sharp Memorial. I've talked to the hospitalist, and they're starting to use it over at Sharp Memorial. I'm getting around as much as I can, but there's only one of me. And so I do a lot of talks, so we're just doing as much education as we can. But it's becoming a bigger topic, so things are going to change. You can also ask about perioperative antipsychotics. That means around the time of your surgery. Oh. Yes, sir.
Function properly.
That's a great question about value of medication. Medicines that were good for you when you are younger and healthier may actually lose their benefit when you get older, and frankly, many of them may become harmful. And we've all, or many of you have heard about this one. How many of you have been told to stop your aspirin? Yeah, a lot of you. Why? Because we learned in this era that you're more likely to have an intracranial hemorrhage and an upper GI bleed, even though the studies in the past were valid. But that's because we have better blood pressure and cholesterol management. So you need to either talk to your primary care physician who's taking care of you, or your specialist and say, what can I stop? And if they don't know, ask for a geriatric or a palliative consultation to be demedicated. Wait, I have to use the person with the, okay, here we go.
I'm wondering about the use of opioids. Do they increase your cognitive decline?
Opioids are a tricky problem because long-term opioids have been found to be safer, according to the American Geriatric Society, for long-term use than nonsteroidals for people with chronic pain generators, severe back pain, severe arthritis of the hip or knee, if you're on an ibuprofen or naproxen. Those medicines interfere with so many things and cause ulcers, kidney damage, liver damage, that the long-term use of those medicines, especially at high doses when you're older, can be very dangerous. Low-dose opioids for the elderly. This patient was on 5 or 10, 3 times a day. It's not a super high dose. Beautifully control their pain, and their cognition remains stable. But the answer is yes, it can, but pain can also cause cognitive decline or risk for delirium. So it's a little bit of a tricky, it's an ethical question. Do we use them or not? You should always, always, always try to use non-pharmacologic management for pain. First step. Second step, topical therapies. Salonpas, capsaicin, massage, heat, anything that works for you that's non-pharmacologic. Tylenol, also very effective, but you can't use that as you get older. You have to keep that under 3 grams a day. Then you just keep moving up the ladder. Problem is the opioid crisis makes it hard for me to prescribe opioids to my patients that have done all that and still have pain. Because now they have to come in every month to pick up their prescription, and the rates of opioid abuse in the elderly are about 15% of that of the younger population. So I worry, but I don't worry as much.
Yes, you've talked about evidence-based medicine and age-appropriate metrics. And I'm wondering if we go to something like a Medicare for all solution that could be coming up, how do you see that affecting the conduct of research in those areas?
Well, I don't know how it would help, if you want my answer. Why would that help the culture problem? This is an intuitive concept.
Looking at these issues, you
Yeah.
said you like evidence-based medicine, but we're not doing a lot of research or enough. So that's given, if we're not doing enough with the current system, if we go to a Medicare for all system, could that change?
Well, of course it could change. I don't see that as changing anything. This is about the evolution of knowledge. People want to do the right thing. Healthcare providers want to do the right things. We're the victims of our success. People are living too long, if you want to put it that way. I say they're living perfectly. We just have to understand how to change healthcare as they get older. And if you don't have the other, I would see the counter to that argument would be if you don't have competition and those types of things, why do the research? So there's 2 sides to that coin, in my opinion. So, but do you know where most research comes from in the world? It comes from us, the United States, far and away. Not a little bit. We are way more than China, Europe, South America. The vast majority of knowledge base regarding these issues is coming from the United States as our system works today. So I don't know why it would get better. I'd have to think more about that to consider that as a possibility.
A couple questions. How would you describe the difference between palliative and hospice care? And also, as far as pain relief, do you have a feeling at all about CBD oil?
Do I have a feeling about CBD oil? Let me answer the first one, because it's much easier. Hospice care is palliative care. However, you're in the last 6 months of life, and that means the government got involved, and you have good parts and bad parts to it. The good part is you get additional cost-free benefits, oxygen, hospital beds, much more nursing care, much more in-home assistance, and those types of things. Won't cost you a penny. Palliative, we started our palliative program for the purpose that people need that level of care much farther upstream and better knowledge. That's where palliative medicine came from as well. It's not that they're different, it's just a medical CMS benefit. That's all it is. The downside is, quote unquote, you have to give up traditional treatments. But what is kind of odd, most people think they're giving up. In fact, they're getting rid of things they should stop doing anyways. So to me, it's kind of a crazy comment. You don't need chemotherapy the day before you die. And you probably shouldn't have had it for the last 3 to 6 months before you die. So just something to think about, just like not having surgery on your aortic stenosis. That's hard for doctors to internalize. It's okay to let it run its course versus doing something, right? In some cases, not all, but some. So when you get on hospice, you have to get rid of the things. I don't call it giving up, I'm saying getting rid of the things that you shouldn't be doing anyways. And then we give you all this other stuff. And palliative medicine just means we can move it farther and farther upstream for whoever needs it, but we have to work within the confines of what the insurance regulations are. I would make a comment. You get a lot of additional, people have Medigap plans because of, Medicare and Medicaid are Medicare for all or Medicaid for all. But most of my patients don't feel it's enough. They need help in that gap, significant help. And so if you have a shared risk contract like an ACO or a Medicare Advantage plan, you can get palliative medicine any time of the day. So, and the other one, CBD oil. What do we used to say about cocaine and Coca-Cola? It gave you energy and you felt great and had so many health benefits until it didn't. What did we do about cigarettes? Same thing, great, give you, I'm good, you can relax, you feel good, until it didn't. CBD oil is contaminated. I talked to an ER doctor the other day, and as a matter of fact, Mitt and I were just talking about it. The two most common reasons, things they're seeing in the emergency room right now are falls over those scooters that people are dropping on the ground and accidents, and overdose of CBD oil. And in the elderly, the CBD, the FDA just came out with a warning because it can cause liver damage, and we know it causes psychosis and other cognitive changes. Yeah, topical too. It absorbs into your body. So I would say be very careful. I'm not saying it may not be good, but the type of research they're quoting, I don't use High Times as a qualified, research magazine. It needs more research, and we'll find out. But I've used Marinol, tablet Marinol, which is always interesting because my patients say I'd like some marijuana and give them tablet Marinol for their nausea. And they're going, oh, I didn't want that. I wanted to smoke it. I go, yeah.
For those of us in the room who are elsewhere who would like to, I'm over here.
Oh, sorry. There you
For
are.
those of us who would like to encourage more research for the elderly population, is there an effective way that we could rattle the cage of something to get that message out there and encourage
Talk to
more?
your medical group and talk to your institutions. That is the best way to do it. Tell them you want to know about this. You want to know what is your hospital that you go to. Call them up today. What does your hospital do to protect me from the effects of cognitive damage when I go into your hospital? And is there somebody who's working on that to make things better? What about functional damage? Those are the things that you should be doing. Asking, we do respond to patients who tell us what they want. But don't be surprised if some of your hospitals, I don't work with all the hospitals, I work in the SHARP system, even though I know many people in other systems, and I'm happy to work with them. But they don't all know this yet. And we can push it forward. If I didn't, I always give the doctors and nurses in the healthcare industry a couple of years for me to get out there. Somebody said they'd heard me speak many times. You've had your chance, healthcare providers. Now I'm bringing it to the public. So.
Should people our age consider trying to get a gerontologist as a primary go-to physician?
Yes, but good luck. There's not enough geriatricians, there's not enough palliative physicians, it just won't happen. But you need to go to a group that teaches geriatric and palliative training and follows the good standards of good geriatric and palliative metrics. So, great. Let me take a few more questions. My wife's going to ask where I am.
Now? Okay. Hello. Have you found, keeping it very simple, are there any positive thinking effects, both cognitively and functionality? Just keeping it simple and thinking positive, research or not, on your patients?
The answer is yes. The more we know, for example, that women who exercise have a dramatic decrease in their risk of hospital-induced delirium. Exercise. You can protect your brain by exercise. Doctors have been saying that for years. Stop drinking. Don't take medicines, this is a little bit trickier one, over-the-counter medicines that have the 2 letters PM next to them. Stop them. Those are anticholinergic medications. Anticholinergic medications. That category of medicines, now I went from simple. I'm a doctor, I can't help myself. I'm going to go complicated. All medicines, or many of them, have anticholinergic burden effect. Some are a little bit, some are a lot. It's scored from 1 to 3. Tylenol PM, Advil PM, all of those PMs with diphenhydramine increase your risk of dementia by 39%. Ambien, yes. Lorazepam, Ambien has the same receptors, acts on the same receptors as benzodiazepines, an addictive medication. That's why it's triplicate now. So you have to be very careful what you agree to. Now, you do need to get good sleep. If you're in the hospital, do this. Chamomile tea, Ramaltion, melatonin, and family presence. Go to a hospital that has single rooms and make sure there's a family member with you at all times. Those things will protect you. Did you know that? Having your family around in the hospital room actually improves outcomes. That comes from the HELP and the NICHE study. They've been validated. The HELP and the NICHE study, you can call your hospitals and ask them, do you use HELP or NICHE protocol when I'm in the hospital? That has been validated in Europe, Asia, United States, that those protocols, very simple, improve outcomes for the elderly. The HELP, Hospital Elder Life Program. The NICHE, that's I don't remember what that mnemonic stands for, but what these do is they help retain your cognitive focus. We know that when we move people to disorienting environments, that their brains can't tolerate the confusion. I'm trying not to get really technical here. But when you make the environment more like home, bring family there, you're talking about up-to-date topics that person likes to talk about. You're not talking about healthcare, but you have people in there doing things other than that. You are not interrupting their sleep. Non-pharmacologic sleep protocol, worst place to get a good night's sleep is the hospital. And we are teaching our doctors that their blood sugar at 3 in the morning or blood pressure at 3 in the morning is not nearly as important as a good night's sleep.
Thank you.
Yeah, so.
I just want to, I'm
Yeah.
sorry. I was going to ask you, we've talked a lot here about the End-of-Life Option Act, and I just want to mention that you may have read that Portugal and Germany both passed laws permitting assisted dying in those countries, which is really quite remarkable. But I just wanted to ask you your opinion about the End-of-Life Option Act.
So my personal opinion is, if you can't tell, I'm about the Assisted Life Living Act. I'm about living well. And more people who understand what I do and how to live well, I would hope would never need the End-of-Life Option Act, because you'd make the right choices not to be there. I respect everybody's choices. It's just not something I do. That's my answer. As I don't participate, because when I was in hospice, I have always been protected by what's called the principle of double effect. Anything I do that happens to cause harm, as long as it's for the purpose of keeping people comfortable and safe, I can do. But if I participate in the End-of-Life Option Act, that will be the first time in my career that I've actually deliberately assisted somebody in taking their own life, and I don't do that.
Okay,
So,
thank you.
thanks.
And thanks, let's thank Dr. Hoefer for this most amazingly informative talk. Amazing.